Coming up this week on Success Won't Come Calling.
Actually, not only is Abi and similar people paying for prescriptions, but you pay a double charge if you take in the two hormones separately. That's just ridiculous. So you can't take one without the other. And so that's a national and international recommendation. Women diagnosed with early menopause or premature ovarian insufficiency should be recommended to take treatment, unless they have an absolute reason not to, such as a hormone-dependent cancer. But otherwise, the recommendation is to take it, and therefore, why should they have to pay for it? You know, when we're recommending it, it's not just a choice thing.
Hello, friends. Simon Gibson here. Welcome to SWCC. If you like the podcast, please click subscribe and you'll know the moment every one of our episodes lands. On the podcast, we talk about the achieving of goals, often through challenges, and I want to find out more about the menopause and how this can affect women in terms of their achievement of their personal and career goals. I want to find out what the menopause is, what its symptoms are, what can be done to support women who are going through this stage of their life, and also what the future holds in terms of any new innovative solutions which are in the pipeline. We need some help to navigate through these complex and interesting issues. And I'm delighted to welcome two guests to the podcast this evening. First of all is Dr Heather Currie, MBE. Dr Currie is a specialist gynecologist. She is widely recognised as one of the UK's most prominent experts in all matters menopause related. Dr Currie is a previous chair of the British Menopause Society and remains co-editor of Post-Reproductive Health, which is the journal of the British Menopause Society. In addition, Dr Currie is the founder and managing director of Menopause Matters, which is an online portfolio of resources for women going through the menopause stage of their life. In recognition of Dr Currie's work for services in clinical health, she was awarded an MBE in 2021. Dr Currie, thank you so much for joining us on the podcast.
Oh, well, thank you for inviting me.
You are most welcome. We're really grateful to you for your expert guidance in this episode, Doctor. Also, my second guest tonight is Abigail Rogers. Abi is an actor whose credentials include the recent Fraser Staunton's production of the pantomime life of Joseph Grimaldi. Abi is 24 years old and has been diagnosed as going through the menopause at this stage of her life, which does place her in a very small percentage of the population of women who go through this period of time at that age. So Abi, thank you also for joining us. It's lovely to meet you.
Yeah, thanks for having me. I'm excited.
Yeah, me too. You're most welcome. So I'll start with Dr Currie, if I may. Let's get straight to the sort of the basics here. What is the menopause, Doctor?
So the word menopause actually means the final period. It's derived from the Greek menos pausos. So menos refers to menstruation or periods, and pausing is from the pausos. So the final period is one point in the stage of transition when a woman changes from having a normal monthly cycle, which is all related to the function of the ovaries, to the point of where the ovaries are not really producing much in the way of hormones anymore. What that means is the lining of the womb isn't continued to be stimulated as it would be in a normal cycle. And part of that stimulation leads to a thickening of the lining, preparing the lining of the womb to accept a fertilized egg if there was a pregnancy. And in the absence of pregnancy, at the end of each monthly cycle, the hormone levels drop and the lining comes away, it's shed, which is the period. So to be able to produce that normal cycle, the ovaries need to have plenty of good quality egg cells. And the whole point is that we have a finite number of egg cells. So at some point, the average age of which is 50, our egg cells are so low in number and quality that they can't develop as they normally would each month, and they can't produce the hormones which are stimulating the lining of the womb to lead to the thickening and then the shedding, the periods. So basically, the word menopause is the final period. the average age of which is 51. But the term menopause we use to refer to all things around that, such as the changes that happen leading up to that point and the changes that happen after, which the underlying part of that is our bodies becoming low on estrogen. So estrogen is a key thing which we need, which has receptors throughout the body. And when ovaries run out of egg cells, can't go through the normal cycle, our body becomes low in estrogen. And so although we refer to menopause as that whole thing around that, what is really the underlying problem is the lack of estrogen.
Thank you so much for that explanation, Dr. Currie. I've got to make an admission. Whilst I was researching this interesting topic, it dawned on me that for reasons I'm not quite clear on, this remains something of a taboo in our society, particularly for us men. Because despite the fact that I'm CEO of a group which employs 150 people, just over 50% of which are women, despite the fact that I have a wife, I have 2 daughters, I have lots of female colleagues and friends, even saying words like menstrual health is very unusual for me, and I don't think I'm the only man. I just wondered, Doctor, am I right in thinking that perhaps this remains, in your experience, something of a taboo conversation? And if so, has there been any improvements in how the menopause is perceived over the years?
So the subject of menopause and all that goes around that is less of a taboo than it used to be. There's much more talk about it now. There's much better awareness of the impact that the symptoms of being low in estrogen. We talk about symptoms of menopause, but as I've explained, it's really about being low in estrogen. So there's much more awareness about the symptoms, what impact they can have, what are the consequences of being low in estrogen. However, when you mention menstrual health, there's still not a lot of talk about menstrual health and periods. And actually, one of the many issues related to this transition is there is this crazy stage called perimenopause. So not only do we have menopause, but we have perimenopause. And that can go on for a number of years. That's really from, it's very unusual for a woman to have completely normally functioning ovaries, which produce a completely normal cycle, and then they stop. It's much more likely that there's a few years where it all goes a bit wonky. So the function of the ovaries just becomes a bit erratic and a bit irregular, and you can have effects of changing period pattern, changing levels of estrogen for a few months, and then it can kind of go back to normal again. So it is a crazy time. It's quite unpredictable, and that can go on in some women for a few years before we get to the point of the eggs being so low in number and quality that then, as I've described, the sort of periods, the hormone levels drop further and the periods stop. And so those periods changing and becoming often unpredictable can actually have a huge impact on women, how they manage that. You know, if women have put up with periods for many, many years, and there are lots of options we can take to stop periods. In some women, as we'll hear from Abi's, periods stop too young, too early, and there's lots of consequences of that. But in the sort of that perimenopausal bit, having unpredicted, heavy, unexpected periods can be really difficult, especially in the workplace, to manage. So I think there's still stigma around talking around that. And I think women have just got on with it and put up with it for years. But there are lots of options for them. There's less stigma and taboo now about menopause. There is still some stigma around some of the consequences of the menopause that I hope we'll get a chance to cover. So we'll talk about symptoms, flushes and sweats and all these things that we can talk about more. But there's also an important consequence on effects on the vagina and bladder. And that can have a big impact. And that, I think there is still stigma about talking about that as well.
I think so. And it's interesting that you should mention this fact that women have just muddled by in the workplace around the whole issue of menstrual health. Perhaps we can help perhaps we can help businesses, men and women, break those taboos down through discussions such as this, and I'm really grateful the way you've kicked us off tonight, Doctor. So over to Abi. Tell us, Abi, when was the first occasion? What were the circumstances in which you first began to research or consider that you might be entering this period of your life, which we term the menopause?
Yeah, so I actually didn't really think anything of it. So my period started, and I only had like a couple, and they were very infrequent. And then when I was 18, I think my mum said, like, maybe we should actually just get this checked out, because I didn't realize it was such a bad thing at that age. And then I had tests done and scans and everything. And then I was told of this diagnosis, which is premature ovarian insufficiency. And so that's like I was told I had no eggs left, and my ovaries weren't producing estrogen. So I had the hormones from my brain telling my ovaries to work, but then the estrogen, I didn't get any estrogen, basically. So it wasn't until after the diagnosis that I actually realized what was going on, and that it was like the menopause. Because even straight away, I didn't realize that's what it was. I know other people like me have had symptoms, more menopausal symptoms, and then that's how they've got checked out. But for me, it was my period stopping.
And at that stage, were you in consultation with your GP? Was that your first port of call?
Yeah, so I had a GP who then referred me to an endocrinologist, and then had my tests done through that. And then she gave me the initial diagnosis. And then the thing that really was bad on my part was that I then didn't get any help from that endocrinologist. She then referred me back to the GP, who then told me to go on the combined pill so that I could get the hormones I needed. But that was basically it, which is also why I like talking about it now, because I was just given no help at all, because a lot of it is psychological. And even as a result of the menopause, that the symptoms can be psychological, but then also getting this diagnosis about being infertile at such a young age, that was what I really needed at that time. And I was just given the pill as my treatment, but wasn't aware of the other options I could have. I wasn't aware of the help I needed, the information, basically, the education around the subject. And it wasn't until last year, so like 6 years after my diagnosis, where I went to my GP about health anxiety. And it was then where he was like, oh, have you experienced anything in your past about your health or anything? And then I brought it up, and then he said that I shouldn't have been left in the dark so much about that, and referred me to a specialist at Chelsea and Westminster Hospital, so a special premature ovarian insufficiency specialist. And then after getting help, I felt so much more confident to talk about it. And that's why I like talking about it now. And I just think it's a common thing with other people like me, and even like women at the generic age of going through the menopause. It just seems to be that there's not the help there. The GPs kind of push it aside a lot of the time. People don't take it seriously. Like you say, in the workplace, people may not take it like a legitimate reason for something, when it can affect women very differently as well.
Of course. Well, thank you so much for sharing that, Abi. And I'm delighted to hear, that after some considerable delay, you have been given the correct signposting and referral by your GP. But Dr. Currie, first of all, in terms of how these symptoms presented themselves to Abi, how much do you regard what you've heard as, how much of that has resonated with your own clinical experience?
Yeah, so I mean, there's lots of things Abi said there that are so important, and one in particular is it affects everyone differently. So yes, for some people, the first sign is periods changing, spreading out, but they may not have much in the other way of symptoms. And another, for some women, they have more in the way of the the sort of effects of the lack of estrogen triggering various reactions. So one is, why we have flushes and sweats or can do, is that estrogen's involved with the temperature control bit in our brain. And the little thermostat goes a bit wonky, basically, with the lack of estrogen. So it thinks our body's overheating when it's not. And that switches on mechanisms to open up the little blood vessels in the skin surface, which is the flush, and also switching on the sweat glands. So this is trying to get rid of heat when it doesn't need to. So, through our normal day, our temperature, our core temperature is changing up and down, but it shouldn't trigger reactions of either trying to cool down or the opposite. Sometimes some women find they shiver, and that's our body's mechanism to try and conserve heat when the thermostat thinks we're a bit cool. So the flushes and sweats are really, really common, the most commonly recognized symptoms, and many women are prepared for that. That doesn't happen in everyone. And another one is mood changes. So anxiety, low mood, difficulty coping, brain fog's often described, joint aches is really common. So all these can be part of the presenting symptoms. But as Abi described, in some women, it's just they have infrequent periods, or they realize they've not had a period for ages. And Abi did absolutely the right thing, to then be investigated at that time. And it is very uncommon in young women, but it can happen. And often what we've heard of is women giving the story. And even, at 18, Abi was no way going to be thinking about menopause, but even if that's in the back of your mind, sometimes women are told, oh, it can't be, you're far too young. But we know it affects, the figure given is that going into menopause early affects about 1% of women under 40 and probably 0.1% under 30. So it is quite uncommon, but it can have a huge impact. It's for all women, to getting to that stage is quite a big deal, because often menopause has been seen as quite negatively. And, we're all younger in our brain than we really are. I still think I'm in my 30s, which is ridiculous.
I thought you were.
Thank you so much. You say all the right things. Anyway, to sort of, in the past, because it's been seen quite negatively, and the sort of, it's always happens to people older than we think we are. And so it's, can't be menopause. I'm not at that stage yet. And that happens to women in the 40s and early 50s. Imagine someone at 18 being faced with that. It's huge. It's enormous. And that the fertility aspect is just huge impact. And I think we are much better at recognizing it even in the last few years. And for Abi to be able to talk about it and, raise awareness of it is just so important. It's fantastic.
It really is. And this issue of a change in the narrative is something that's even come across to me in my research and trying to get myself up to speed. I looked at, for example, I know that Davina McCall has done a program, Sex Myths and the Menopause. I've read an excerpt of a book called Period Power. I'll have to find out who the author is on that, and we're going to put the links to those on our socials. But what came across to me was that in the past, the menopause has been something which women have been perhaps even expected to sort of get on with quietly and having a purely negative impact. Whereas it feels to me, certainly from the narrative at the very least, that there's that it's seen more of as a transition, which could lead perhaps to more empowerment and more confidence in a woman's body and in themselves. I just wonder, is that anything which strikes a chord with you, Abi?
Yeah, well, that, you just reminded me then of talking about the documentary. That was a really big turning point for me last year, because I could see other people like me, and there was someone specifically who had my condition, so I could relate to her. But even just hearing other people talk about the menopause and that kind of thing, it made me feel like I wanted to talk about it with my friends. So not just for people like me, but so that they could support their mums or their people they work with. Because at drama school, there was a teacher go through the menopause, and we always joke about her hot flushes and everything. And I was there, but I was I had a lot more sympathy and empathy for her after hearing about all these women's experiences and that kind of thing. So that's why I just think it's so important to not not feel embarrassed for that person or whatever, to support them and see what you can do to help them, and just be aware of things, because things can be a lot bigger issue than what they may seem as just someone just going through the menopause. Oh, like she's hit that age, that kind of thing.
Well, do you know what? I mean, again, I feel a bit shameful when I say this sort of thing, but I remember my mum always used to say to me, ignore me, it's just my age. It's just the change. And then, of course, we enter into euphemisms like time of the month, nudge, nudge type of things, don't we? Yeah. And I mean, I'm talking here from a man's perspective, but it's strange, isn't it? Because if you're friends with someone or you work with someone who suffers from backache or migraines or anxiety, you think nothing of saying to them, how's your migraines? How have you experienced anything? Anything I can do to help? Do you want to take, anything like that? And yet there is more of like a nudge and a wink around this this topic, which I think particularly us men and businesses need to be a bit more savvy and sort of grow up a bit and have grown up conversations about it.
It's even like my friends that are my age that are guys, there's some of them do try very hard to not feel awkward, but some are visibly awkward when me and my girls talk about periods and stuff like that. And we try and encourage them that we want to talk about it because we like talking about it. It helps girls when they talk about things going on. So my friend's going through like PMS or that kind of thing. And so you shying away makes us feel like we shouldn't talk about it, which makes us want to talk about it more.
Of course. And I mean, just our listenership and viewership is about 50-50 between men and women. And hopefully the fact that it's me who's sort of chairing this discussion makes other people think, well, if he's quite comfortable in having conversations on it, perhaps we all should be. And just the other point I'd just like to flag is I'm really conscious we're talking about women and girls here as being the ones predominantly affected by the menopause. I'm really cognizant of the fact that the transgender and non-binary communities will also have experiences of this. Any folks from those communities who are watching and listening, I really hope that this is of great benefit and interest to you also. Dr. Currie, just in terms of the journey of clinical support that Abi experienced, from the way she described the first visit to a GP leading to a referral, which perhaps only got to half the problem, then back to the GP, then nothing. Is that something that you have seen yourself from patients who've been referred to you? And if so, is that a lack of education?
So actually, Abi's experience wasn't great, and we would hope that even in the last 6 years, it has improved. There's a huge amount of education going on related to menopause and treatment options, and including premature ovarian insufficiency. And what's happened, I think what kind of led to a backward step with menopause education was in the early 2000s. And there's been work going on with menopause, for way longer than that. And there's a number of us have been running clinics for way longer than that. And we have seen a huge change in that time. So pre-2000, there was a lot of interest in menopause. There was lots of educational meetings. There was lots of new treatment types of HRT preparations coming out. There was a lot of buzz around it. What then happened in the early 2000s is there was publication of some trials from America, which focused on risks of hormone replacement therapy and didn't sort of balance that against the benefits. The publicity around that was enormous, and the headlines were really, really scary, regardless of the fact that subsequent review of these papers showed that the risks were actually, hormone replacement therapy is not perfect, but actually it's got lots of benefits. And for many women, especially the younger women like Abi, there were way more benefits than risks. And so because of that whole publicity, the adverse publicity, there seemed to be less interest, not only in HRT, but in menopause in general. And attendance at meetings wasn't so good. There wasn't as much, going on. And it's taken a long time for many of us just working away, drip feeding, continuing with the education, trying to get the balance back. It's taken an awful long time to get to the point where we are now, and there's masses of people have been part of that. And we have, yes, you mentioned Davina's program. It was fantastic. There's been other programs before that. There's just been a gradual sea change of much more interest in menopause, and much more recognition about the role of HRT, but also other treatment options. But again, a sort of realization, actually, this is really important. This does affect all women, and we need to be up to speed with this. And understandably, I think a lot of healthcare professionals themselves lost interest because they felt, well, HRT was the main thing we were offering, and if we're not doing that anymore, we know that some practices just decided to stop prescribing it altogether. But in that time, menopause didn't go away. So, more and more women continued to become menopausal. And the other big thing that I think has happened has been a huge role in society with women. So you mentioned your mum, talking about it's my age. I don't ever remember my mum mentioning anything about what she was going to, because they didn't. And we have more women in the workforce now than ever before. So what that means is not only are they're often working sometimes full-time, sometimes more than one job, but they're also still running the households and running after their kids and their elderly relatives as well. I mean, the role in society has changed massively. That's not suggesting previous generations had an easy time of it, absolutely not, but it was different, and how you cope with symptoms when you're in work and doing all the other things might be quite different than if you didn't have all those pressures on you. So in that time, there's been a huge road change in the interest in menopause in general and with HRT that has got to the point now where we have loads of education going on. I work very closely with the British Menopause Society. As you mentioned in the intro, our meetings are all oversubscribed. We have increasing membership all the time. There is a great interest now. There's a great need for knowledge, and there's lots and lots of resources being provided. So even in the last 6 years, Abi, I would hope that things are a lot better than they were for you then.
Well, let's talk about that. First of all, might I say, Dr. Currie, I'm sure that you're right about the progress, and I have to give you credit as one of the main leaders of that. And I think the fact you've been recognised with the MBE is you couldn't get much more of a recognition than that. So I'm sure that Abi and lots of others listening are very grateful to you for your pioneering approach to this area. So well done, you.
Not just me. There's been loads of people working very hard.
Yes, I'm sure there has been. So I want to just link in, Abi, if I may, with the point that Dr. Currie's just been making about the potential solutions or the help that is out there in terms of clinical help or any help. Since you've received your diagnosis, have you undergone any sort of clinical procedures, any sort of HRT? HRT, presumably, is that hormone replacement therapy, Doctor?
Yeah, it is, absolutely.
So, Abi, have you undergone anything of that nature?
Yes. So, well, like I said earlier, I was on the pill, combined pill for estrogen and progesterone when I was diagnosed. I just knew I had to be on it because I was told that I need estrogen for my bones and progesterone for womb lining. And then, so I took that for about 5 years, I think it was. And I'm constantly going back to my doctor about it because I didn't particularly want to take it, only because I had only heard from like my friends how many risks there are with it, even though like that's just what you hear. And so it wasn't until last year when I spoke to this doctor who referred me to the specialist, and they thought I might benefit from being on HRT, because it's also a separate thing. So you have your estrogen and progesterone can balance it, and then they can track it as well. So like, as in more, do blood tests and see what levels you need to go to. So it's been kind of a year journey for me with HRT. So I started on a gel and the progesterone pill. And I didn't like the gel. It was really annoying. And then I could see from other people on Instagram and things that I follow, they had the patch, and I was like, oh, I kind of want to try the patch. That sounds more easy to use. So then I went onto the patch, and then I changed my dosage. I went up a dosage to help with, because my main symptoms are more like psychological, so anxiety, and they thought that might help going up the patch again. And now I'm on a good level of estrogen where I'm getting the right amount according to my blood tests and where they're happy with. So that's kind of where I am at the moment. But it's literally just changed recently because I kept on getting periods when I wasn't meant to be because I was taking the pill continuously. And so I've now changed to doing like breaking it up so that I have a period every month, that kind of thing. But right now with my specialist, I feel a lot more supported and feel like they're there with me and changing it up according to what I need at this stage in my life, kind of thing. So
and so clearly you've just explained there how your periods are now they're being properly managed, if I could put it that way. You're being helped to achieve a frequency which works for you. What about your anxiety? How are you? Has the HRT helped you in that regard?
Yeah, I do think it has. Like before I started the HRT and when I was on the pill, my anxiety has improved drastically. And then even going up a dosage to the higher estrogen, and now being on the estrogen that they're happy for me to be at, I still am an anxious person. Like I have anxiety, but it does feel a lot more controllable and managed. Yeah.
Well, I mean, if I may say, you're coming across as so calm and clear on this subject. So well done to you for that. Dr. Currie, you mentioned risk earlier. And a lot of what we talk about on the podcast is every challenge we face, usually there's a way forward which involves reward if we're prepared to take some form of risk. Abi's summarised the benefits that she's received from following doctor's orders in terms of this HRT treatment and the consequential clinical support. What are the risks involved in this sort of treatment, and are they worth taking, bearing in mind the benefits that Abi's describing?
Yeah, so first of all, just to sort of clarify, the whole point of HRT hormone replacement therapy is to replace the estrogen, which kind of makes sense because we talked about the consequences being due to us becoming low in estrogen because our ovaries stop producing it. And so estrogen can be taken in various forms. It can be taken as a daily tablet, a patch, as Abi described, or a daily gel. And the most recent new kid on the block is a spray that's applied daily. So that's different ways of taking estrogen. There isn't one way that suits everyone. And the big thing about managing menopause or premature ovarian insufficiency in all women is to individualize. So there isn't one type that suits everyone. It is about tweaking it. And as Abi's discovered, taking that time to tweak it and minimize side effects and maximize benefits and go by symptom control, how are you feeling, is hugely important, is essential. And especially, Abi's looking at being on this for a long time. So we don't want something that's going to make her feel worse just for these presumed benefits years later. You often need a bit of tweaking to get it right. As Abi described, also, there is another hormone involved, progesterone or progesterone, and that's because if we just give estrogen in whatever form, it could stimulate the lining of the womb. So that is a risk if estrogen is taken on its own in someone who still has their womb or the uterus. So if with estrogen on its own, it could actually increase the risk of a thickening of the lining and eventually cancer of the lining of the womb. So it's really important to balance the estrogen with progesterone. If a woman has had a hysterectomy, had a womb removed, then usually she can just take estrogen. But otherwise, we need a combination. So with the progesterone, that can be taken as a separate capsule, as Abi described, or it can be taken combined in a tablet, or it can be taken combined in a patch, or there's even a little intrauterine system, a little coil that can sit in the womb and it releases progesterone there. So there's lots of different options. So when we talk about risk, it's related to the type of HRT, it's related to the route of HRT. The risk that there's the main concern for most women, which was emphasized in the studies I talked about in early 2000s, which caused the whole lack of confidence in using and prescribing HRT, is related to breast cancer. So the current information, the current understanding of the association is that if HRT, combined HRT, so that's when we use estrogen and progesterone, if it's taken for more than 5 years after the age of 50. So Abi doesn't even start counting until she's 50, because she's just replacing the hormones that would normally be there anyway. So if it's taken beyond the age of 50, there is a small increased risk of breast cancer. And that's something like, there was so many different studies, so many reviews and analyses, that there isn't one figure that everyone's agreed on, but it's something like an extra 4 to 8 cases of breast cancer per 1,000 women over those 5 years after the age of 50. So it's a small risk, and you have to balance that against the benefits. The current thinking isn't that HRT causes breast cells to turn into cancer, but more that it may promote the growth of cancer cells that's already present. So from breast cells to turn into cancer, it can take quite a number of years before that becomes a clinically detectable cancer, either from mammographic screening or from examination. The women who can take estrogen-only HRT, it's felt that there's little or no increased risk of breast cancer. We can't say there's no risk at all, but the risk with estrogen-only seems to be much less. It seems to be the combination of hormones which can stimulate those cells in some women. So that is the main thing that's caused a huge concern. And, it's all around how risk is presented and how it's perceived. So in the newspaper and television articles and radio articles and everything that happened in the early 2000s, it was portrayed as a percentage increased risk. So if something is saying the risk is doubled or there's a 25% increase, that sounds massive. But if you based it on a small number, it's still a small number. Something can be doubled or 50% increase, but still be small numbers. And the important thing to get it in perspective is the actual numbers. And we do know that, there are other factors such as being overweight or drinking a fair amount of alcohol probably has a bigger risk, especially the alcohol, than the use of HRT. So against that is really important to understand the benefits. And so, you shouldn't just look at risk, you should look at benefits. So the benefits are, it is the recommended gold standard treatment for symptom control. It is the most effective treatment we have for controlling those effects of being low in estrogen. We know it's good for bone health, which is really important for Abi, and also for heart health. So if someone loses the estrogen at a younger age than normal, when we talk about long-term consequences, so the symptoms we've talked about at the moment are these early signs of being low in estrogen. We then have intermediate signs, which I've mentioned a little bit already, to affecting the vagina and bladder, but long-term consequences is affecting bone health, so increased risk of osteoporosis and fracture, and also heart health. So estrogen taken in those early years of the menopause, and particularly for young women, protects against heart problems and also osteoporosis. So these are the benefits, and you balance them against the risks. Another risk that we have with tablet form of HRT is a small increased risk of a deep vein thrombosis. And so if someone has risk factors for that, we'd usually recommend taking the estrogen through the skin. So that's known as transdermal. That's the patch, the gel, or the spray, rather than the daily tablet. But for many women, a daily tablet is absolutely fine and will give them still more benefits than risks.
And in terms of the DVT risk, is there anything to be said if that's identified for combining the estrogen treatment with a blood thinner, for example, warfarin? Or
you would only really have a blood thinner if they'd had problems before and were felt to be an ongoing long-term risk of having another DVT, for example. So if someone's had a past history or risk factors such as being overweight, for example, that would be an indication to choose the route carefully. So to recommend it through the skin rather than the tablet. But if there's no risk factors, the risk is still small. And if there are no risk factors and a woman would prefer just to take a daily tablet, that's absolutely fine.
It's interesting, isn't it? Because we talk about this issue of risk and benefits a lot on the podcast in so many different topics. And the problem we keep coming up against is that in terms of the way the media and social media tends to report things, headlines like risk of X doubles will grab the attention, whereas incremental improvements in clinical outcomes achieved over a series of years, backed up by studies. You can't quite squeeze that into some clickbait, can you? So it ends up being that all of the negatives grab the headlines and all of the incremental positives don't, which obviously drives behaviours. So it's so important we have these long-form debates when we fill in a bit more granular detail for people who are watching and listening.
Yeah, and the headlines from these, over 20 years ago now are what people remember. So even though there was subsequent reports saying, actually, there are more benefits than risk, fairly early after that, we were getting reanalysis of the data telling us it wasn't so bad after all, but many people still remembered the headlines. And the other thing about risk that's really important is women's perception of risk. So again, that's very individual. So, if I have a patient that has no family history of breast cancer, that hasn't any concerns about that, if I say the extra risk is this few number per 1,000, that would probably, that's very small, then I'll just take the HRT. Thank you very much. I feel really good on it, and that's all fine. But if someone's had a family history, if someone close to them had breast cancer, even a small number is going to have a bigger meaning to that woman if they've experienced that within the family or friend or whatever. So our perception of risk is very individualized as well. And I can't say to someone, you don't need to worry about that number. It's what she feels about it and built in with her past experience as well.
Absolutely. I mean, what you've just described, Doctor, resonates with me a little. I had an embolism about 10 years ago, pulmonary embolism, a PE, which is a blood clot on my lung. So I got that with I didn't know I had a problem. I collapsed. There was a few days where it was a little bit touch and go. I pulled through, and the cardiologist who was advising me, he said, look, I mean, at the time I was 33, and he said, look, my advice to you is to have quite extreme surgery in terms of heart and lung surgery in order to just correct the impact of this clot. And what he was saying was, there is risk involved in that. It's a big operation, but the outcome you might get could be a much more active life than you would have if you didn't have the surgery. I decided it wasn't worth the risk and that I was going to crack on as normal. And it's all turned out quite well because what he was predicting was going to happen hasn't. And I live quite an active lifestyle now. But of course, medics don't have crystal balls, do they? And you are quite right that things can happen which, nobody would have predicted.
Yeah, absolutely. It's very individualized.
Abi, just in terms of, so you've given us some detail today of the support that you've moved on to, and it's wonderful to hear that this is working for you. How does this all work from an NHS perspective? Have you received these referrals and this ongoing excellent treatment that you've described? Is this all through the NHS?
Yeah. So the specialist was referred to from my GP, and that's all NHS, and they're amazing. The people I've spoken to at Chelsea and Westminster, it just feels so comforting knowing, like, speaking to people who know what they're talking about. Like, I know that, like, GPs do their best, but some that I've spoken to, they didn't give me the information I needed. And even the GP who referred me to the specialist, he even admitted to me, he was like, I know what this is, but I don't think I can give you the support you need. I don't know enough. And even just saying that was actually reassuring to know that he was putting me on the right path. And he literally immediately rang up to someone asking what he should do to refer me to the right person. And yeah, now I feel so much more supported. I get check-ins with them. They monitor my blood tests and then can see my levels of estrogen. I've now had bone scans, which is like what you mentioned about the bone health. I wasn't getting that before, and now I feel like if something was to be affecting my bones, I'd be able to catch that because I'd be having my scans every year, that kind of thing. Because even my first scan I had last year, they told me it was on kind of like the osteopenia level, which is just before osteoporosis, and that's quite easily reversible at my age. So, like, I feel okay about it. I'm fine about that. But it almost worries me that if I didn't have the help there, what would I have known? And that kind of thing.
Absolutely. I mean, if I may, credit to your GP, first of all, for acknowledging that he or she doesn't know everything and to take the opportunity of sourcing that knowledge rather than pretending they've already got it. But question for Dr. Currie, is this treatment, this quality of treatment that Abi has described, readily available under the NHS? So I guess that's the first question.
So I'd also just want to add credit to your GP and all the GPs out there. They do an amazing job, and they can't be experts in anything. Everything. They can't be experts in everything. And what our vision, so when I say the British Menopause Society, our vision for menopause care in the UK is that GP practices, they don't all need to know everything about it. It's good to have a basic understanding to help women to know what to look out for. But if every practice had someone with an interest, that would be fantastic. And then every primary care team has a regional or area specialist menopause service that they can refer to, that they can continue education with, that they can get support with. And we are working really hard to get to that point. In Scotland, we just about have every health board now has a specialist service. So it's the specialist services that would provide that extra detail, that extra tweaking, that extra assessment that's required for young women like Abi. The general menopause care is perfectly adequately provided in most cases within the primary care teams, and that's how it should be. But, we know that there hasn't been consistency with the advice that women were getting generally, and it's to do with that whole thing that happened in the early 2000s when a lot of people became understandably completely concerned about prescribing HRT because they'd been given this information about the risks. And then gradually, as that message has gone and turned around, we know that generally most menopause care can be provided in primary care. But what we need is that they have access to the specialist services. And this is within the NHS. There are quite a lot of private clinics, but, my dream is that there shouldn't be a need for that it is all provided with the NHS. The NHS is under huge strain. But despite that, we have been continuing with the education and continuing with training so that we produce menopause specialists and they can run the services. The other thing that has been a problem is that sometimes there hasn't been the investment or the interest in funding specialist services. But again, I think that's something that's changing. I think generally the people that commission healthcare services are hopefully getting the message that this is really important and these services are needed. So there's still a long way to go. What's being provided at the moment is not perfect. It's a lot better than it was. And there's such a great interest and enthusiasm for getting better and continuing with education.
Yes, that has to be right that this is important. I'm delighted to hear that from the point of view of the NHS that the services available are heading in the right direction and in Abi's case have worked very well. Because bearing in mind the potential impediment that this stage in a woman's life could cause to her personal and her professional goals, it can't be right that anyone would be restricted from accessing the help they need to overcome any challenges faced by economic issues. So it's so reassuring and positive to hear that the position with public health should mean that if a woman is listening to this podcast who Abi's story resonates with, that they should step forward into the healthcare system with confidence that there are solutions and support available.
Yeah.
Absolutely.
Also, I'd like to say on that, like the what you're saying about accessibility in terms of that's the NHS. I know there's quite a few women who have campaigned about getting HRT free prescriptions because. So for me, I had my the pill free because it's a contraceptive. So I had that free for 5-6 years. Now I'm on HRT. I have to pay for my prescriptions, and for a lot of women, that's a lot. And especially if you get diagnosed early in your life, that's a lot of years of paying for a prescription. That's something that's so vital to your health. And I know there's been movements and it's gone to the government and that kind of thing. But it's just raising awareness for that, so people are aware that that's a thing that women also have to deal with on top of all the other things.
Well, indeed. And Dr. Currie, what's your views on that? Is because it sounds to me that this is a really important part of the care that Abis receive. Do we need to lobby the government in terms of making this really important treatment available under public health?
So as Abi was saying, there has been quite a lot of work looking at that, and there was agreement that prescriptions could be given for longer. I don't know if that's actually been implemented. So actually, not only is Abi and similar people paying for prescriptions, but you pay a double charge if you're taking the two hormones separately. And that's just ridiculous. So you can't take one without the other. If you were taking a tablet that every day contained both hormones, that's one charge. But if you're taking a different sort of regime throughout the month, then that's a double charge. It's just crazy. So particularly for Abi, for young women in whom the recommendation is not just a choice thing. The recommendation is that they should take some hormonal treatment at least until the early 50s, the average age of menopause, because you're not only treating the symptoms of being low in estrogen, you're also preventing, those later health effects. So you're also providing treatment for bone health and heart health. And so that's a national and international recommendation. Women diagnosed with early menopause or premature ovarian insufficiency should be recommended to take treatment, unless they have an absolute reason not to, such as a hormone-dependent cancer. But otherwise, the recommendation is to take it. And therefore, why should they have to pay for it? When we're recommending it, it's not just a choice thing. But even with women then who are at the normal age of menopause and they choose to take it, then it's great that at least they're going to be able to get longer extended prescriptions. I'm aware of some women that have had to pay even a single charge or a double charge every 3 months or so, which is just ridiculous. I am spoiled because in Scotland our prescriptions are free, but it would be much nicer in England as well if there was something different happening, so there wasn't such a cost effect.
Well, indeed, because it can't be right, can it, that in a world and in a society where we quite properly strive for equality of opportunity, that a woman might be faced with inequality of opportunity based upon her economic circumstance to afford this really important treatment. And I know that we've got a number of MPs who listen to this podcast, and I do think that if this is not being prioritised, bearing in mind that 50% of the population might well be faced with the need for this treatment and really benefit from the treatment, then it's got to fit quite highly, shouldn't it, in the rank of priorities? Do you agree with that, Dr. Currie?
Yes, I do, but I am aware there is a lot of work going on, so that's great that people are doing something about this. It's fantastic.
Definitely. I wanted to just move on now then to this issue of how this period in a woman's life can affect her career and her life goals. Jacob, have you got that Sky News report I spotted? This was quite a recent report that I spotted. I think it was from the back end of 2021. I think you guys can probably see this. This is a Sky News report. The headline, for anyone who's just listening on this, those on YouTube will be able to see it. Menopause forces women to leave their job or pass up promotion, this study finds. I know that Davina McCall was actually involved in this study, along with a clinician who, Dr. Louise Newson, was involved in this study. And I mean, some of the statistics in here are quite significant. 59% of women took time off work due to menopause type symptoms. 18%, so 1 in 5, were off for more than 8 weeks. We've got information around reduced efficiency at work, poor concentration, lack of quality of work. So it's what is clear from this study is that this is a period of a woman's life where, unless they access the right support, either through clinical means, but also through support from their employer, that the risk that their career could be impeded is very real. Now, I reached out to Dr. Currie when I read a really interesting suggestion that she made when being interviewed by the Times, that businesses should have a menopause champion. So, Dr. Currie, tell me a little bit more about that suggestion, which has really got me and my colleagues at the Spiring Group interested. But tell me just your thought process behind that suggestion.
Yeah, so it came about from a few things. One was the realization and the sort of sharing from women that some of them don't feel comfortable going to their line manager because they're worried that they think the line manager may think they can't do the job. And along with that is that whole, this is menopause, this is personal, this is me, do I want to share this, and not always feeling comfortable to talk about it. And so I've had that experience of women telling me that, and how they very much appreciated having someone not directly involved in their work that they can just talk to, and often just really appreciate someone to listen to them and signpost them to various resources, and tell them they're not going crazy. Actually, these are the consequences, and there are treatment options for this. And then another sort of angle to that was doing a webinar for a company who had themselves come up with the idea of having a menopause champion, so that again it's someone impartial that people in the organisation know they can go and have a chat to. In our own organisation in Dumfries and Galloway, we kind of done that without realising that we were doing that, in that we have a specialist nurse who staff know they can go to and phone her up or arrange an appointment and just have a chat and just run things by her, and have found huge support, from that process. It doesn't really matter what you call it or what it is. The whole concept is just having a menopause something. So just having that recognition that menopause and the symptoms of menopause can, as this survey that you mentioned and previous surveys have shown, can have a huge impact. So when we're talking about menopause and consequences, it's not just about how many flushes someone's having, what are the actual symptoms, is what is the impact of that. And if it's affecting their ability to carry out their job, their work in the way they want to, if it's affecting their confidence, if it's causing them to be more anxious about aspects of the job that they've done for years without a problem, if it's causing them to have disturbed sleep, so they're exhausted when they come into work, just the recognition of all that can happen, and having some way that women can go to talk through it, to think about simple things that might help, like, is there a fan nearby? What's the ventilation like? How near are the loos? If your period comes unexpectedly, is there some flexibility on the timing of the hours? If there's disturbed sleep, and just something, just a menopause something, recognition that menopausal symptoms can have an impact in the workplace. More women are working now than ever before, so this is actually really important. And then to not necessarily actually start treatments, obviously, but to signpost and just to show where resources are and say, have a look at this information. And the other thing that we found really helpful in our organisation was starting with occupational health. So we were aware that many women were having to take time off work or even retire early, and rarely on the sick note would it say due to menopause. It's more likely to say anxiety or depression or stress or fatigue. And so we worked with our occupational health department to know that, so that they knew what to look out for. And sometimes it's them that's picking it up, that, they have a talk about all the symptoms the woman's experiencing, and then they'll say, what about your periods? You're in your 40s or your 50s, and are other things changing? And it's linking them together that sometimes doesn't happen. And it will only happen if women more and more know what to look out for, and know what the possibilities are and what they can do about it. So it's not just a menopause champion, it's just having a menopause something recognition. It might be a framework, it might be a policy, but the idea of having that person that's impartial, that can give that advice and support and signpost to resources, just feels like a good idea.
But also as well, just having someone there or the information available at your work or whatever just makes it almost less embarrassing, because I think a lot of women find it embarrassing, the symptoms, or just having to say they're suffering with menopausal symptoms or something. So just having something there to make it seem, like we talked about earlier, seem less taboo, and that we can talk about it with our employers or whatever, and not feel like it's an embarrassing thing to have to deal with.
How well has the entertainment profession or the acting profession taken on board this issue of the menopause? Have you heard of any specific support available?
So I think, like, the industry I'm in, so I do a lot of musical theatre, and it's a lot of younger people. So I've not come across anyone that I've been able to relate to in my work yet, in terms of the menopause, and it's never been mentioned. But the thing I love about the acting world and everything is that people are always creating new plays or new films about issues. And I know that someone I went to drama school with created a play about premature ovarian insufficiency, and these lovely girls, Erin and Emma, are doing a film called Paused, which is about a young girl going through the early menopause. And so I think it's more talked about in new works to try and spread awareness. I've not come across it in terms of dealing with it in the workplace as of yet.
But I think that having someone like yourself who's able to impart that experience, I think that anyone in who's a sort of decision maker in the acting profession should perhaps see this as an opportunity to do exactly what Dr. Currie has suggested, and to perhaps embrace and put this resource in place where other actors, whatever their age, who are faced with those situations can perhaps consult directly with, as I say, a resource which is available to them, which could not only help their career, but could just create a more supportive profession generally.
Yeah, I guess as well, because in my industry, you work with people of all ages as well. So it's about, like I said earlier, like me talking about it with my friends, it's about how my acting friends, how they can work with someone who's going through the menopause and suffering with symptoms. And so that kind of thing. So just, again, spreading the awareness.
Absolutely.
You don't know who you're going to work with. And in some jobs, a lot of people are similar ages, so they can relate. But I could be working with someone a lot older than me or a lot younger than me, like that kind of thing. So,
of course. And I mean, it's that creation of a culture, an open and positive environment where all needs for support can be identified and spoken about and addressed via a plan which will help. So I completely understand what you're saying there, Abi. Let me just tell you about what we've done historically in the Aspiring Group for well-being of our teams. And I'm going to just try and work out what we can do to implement both of your views. Now, first of all, I spoke to our HR director, Laura, earlier on today, and Laura is listening with bated breath to this podcast, and she has her plan literally ready to write. But we decided a couple of years ago to bring a well-being coach into the business. Her name's Sian Quip. She's actually been a guest on the podcast before, and I managed to grab a few minutes with Sian earlier. Sian's profession is she's a cognitive hypnotherapist. But she's a general well-being coach in terms of the work she does for employers. And what Dr. Currie suggested in terms of this independent route to support, I was really pleased when I heard this, because this is what we implemented a couple of years ago. What we decided was that all of our team could access Sian without any form of referral. So they don't have to go via their line manager. They don't have to go via HR. They haven't got to write like a report on why they need to see Sian. They just contact Sian directly. Sian doesn't need to report to us or to prepare a summary for the HR file. We trust our team to seek that resource of Sian's time if they need it, and we trust Sian to give them the right advice. Now, when I talked through with Sian about the conversation we were going to be having, she came up with a number of really good suggestions. We have an internal hub of information for our teams, which includes things like how to manage anxiety, how to look after your physical health, all of these sorts of things. And she suggested that we actually have a specific information bank on women who are going through the menopause. So I guess my first question is that one potential solution that we should be considering, and that what other employers should as well?
I think that's fantastic, because there's loads of resources available that you could easily link into. And I've heard of other organisations that have done that within their own intranet. They have got a menopause page, and they've got all sorts of stuff on there, and, forum chats and all that kind of thing. So yes, that gets my support.
Abi, what do you think?
Yeah, that really does sound great. Like, the whole thing with my diagnosis is where to find the information about things, and it's all been all over the place. But having a direct route is a lot more helpful, because it can just take that feeling of being overwhelmed with loads of different pieces of information, and takes that away. And yeah, that does sound amazing.
Well, Laura, you're listening. Get cracking. You've got to report back to me by tomorrow morning to let me know that the intranet's up and running. No, I mean, that's wonderful to hear. And I guess the other thing which came to my mind is, as business leaders and managers and just the staff, perhaps my problem that I've managed to overcome in just talking about menstrual health, perhaps if I as leader can kind of just sit down and have those sort of conversations with staff, and let them know that whatever their need for support is, if it's a man who's got a migraine or if it's a woman who's going through the menopause, that we'll be there to support them and apply different resources and support depending upon their individualized requirements.
Yeah, completely. Just opening up the conversation.
Yeah.
Coffee break, As you said earlier, if you knew someone suffered from migraines or whatever, you would say, how's your migraines getting on? So, would you get to the point of saying, how's your menopause going?
Yes.
Why not?
Indeed. Why not?
And the only other thing around that is that some women, despite all this increased talking, which is fantastic, it's becoming less of a taboo, some women just still don't want to talk about it, and that's fine. It's just knowing that resources and support is available. But if they feel that's personal to me and I don't feel I need to share it, then that's fine as well. But it is options.
It's having the help available that you can access for those who perhaps aren't comfortable in airing this in public, that they can access confidential support, and those who are, being able to normalise it and bringing it in within a healthy, open business culture. Then both of those solutions seem very rational to me.
Yeah, exactly.
Right, well, on to the future, just to finish off. So first of all, Dr. Currie, obviously you've been a pioneer of the progress that's been made in UK health over the past years. What are your hopes if we met back up in say 3 years' time? What are your hopes for the way menopause is diagnosed and supported through the clinical system and through society generally?
Well, I always have hopes and ambitions and things that I want to achieve. So the first thing is around information. So it is a lot better, but there's still more we can do. So the ideal would be that all women know what to look out for, that the education starts at school so that people know what to expect, what the bodies are going to go through, what the changes are, when that can happen. So happening early is recognized and dealt with at the time, so that women know what their treatment options are, know what diet and lifestyle things they can do themselves to improve their health later on. And for healthcare professionals, for them to have confidence to be able to also know what to look out for, because people can present in many different ways. There's such a range of menopausal symptoms that if it's not recognized as being hormonal, you may end up with lots of different referrals. So I've known of women being referred to neurology because of headaches they were having, referred to cardiology because of palpitations, referred to rheumatology because of joint aches, and then there's the mood changes. If it's not recognized, this can be hormonal. There's a lot of extra necessary stuff that can happen. And for there to be these in primary cares, people with a special interest, so that if someone, because a lot of women will actually get the information and be able to manage their menopause themselves, but if they do need help and want to look at specific treatments, then they need to go to their primary care team, and for each team to have someone with a special interest, and then for all the regions to be able to have a menopause specialist service. This sounds like too much. Is it unachievable? I like to be positive, and that would be fantastic. With treatments, then there are new things being developed. So there's new types of HRT. For example, we now have daily spray, which we've only had fairly recently. HRT has masses of benefits, more than the risks, but not all women can take HRT. Not all women would want to take HRT. And there are developments on other options. There's a chemical that's been found to interact with the brain that can be really, really helpful for controlling the flushes and the sweats, and there's more work going on with that. And at some point in the future, there is a glimmer of hope for people like Abi who have lost the function of the ovaries at a very young age, and there has been research showing that we can. There's a way that in animals, so far it's not, as far as I'm aware, in humans we can restart that development of ovaries. So not of ovaries, sorry, of egg cells. So if we go right back to the beginning, I said this is all around. We have a finite number of egg cells, and we run out at some point. But actually, there is now research looking at getting this, what we call stem cells, so cells that will reproduce new egg cells. So for young women to have this concept of being able to develop new egg cells would absolutely be a dream come true. That would be fantastic. I'm in my 60s. The thought of having new egg cells and going back to having monthly periods doesn't fill me with joy. So, but for the younger women especially, that would be a fantastic development. So that's sort of looking at information, treatments, and something, completely new in the future is what I would love to see.
Well, it's great to hear that despite all of the progress that we've already made, and which you've been helpful in pioneering, Doctor, is that there's still this innovation in the background. There's good cause for positivity, and I think a lot of people are going to be very reassured by that. Abi, how about you? I'm fascinated to hear what's next for you from an acting perspective. You're off on tour shortly, aren't you?
Yeah, I'm touring Austria for 5 months with a play. So yeah, and then who knows after that, because that's how acting works. You have a job and then who knows what's coming next. But yeah, excited.
And do you have to, in the acting world, do you have to specialise in, say, theatre, or in due course, do you have an ambition to diversify into TV and film, for example?
Yeah, so my training is in musical theatre and instruments in acting as well. And so I've done a lot of theatre in my training, but I would love to get into film and TV. That's a big goal.
Well, I know that it will be one that you achieve. And what's come across to me in spades today, Abi, is that you've not let the fact that you've entered this stage of your life hold you back. Are you determined that you will move forward in a similar way, and perhaps also that your story will be inspirational to other young women who perhaps are faced with the same scenario?
Yeah, no, definitely. I'm just so passionate about this, and I'd love to integrate it in with acting in a way of spreading awareness. Like I said, with this, people doing films about it. It's just such an amazing way of spreading awareness, because so much of our education comes from films and TV shows and seeing characters go through things and then thinking, oh, that's really relatable, and it actually really helping someone. So it would be amazing to tie that in. But yeah, I've just really like speaking about it with friends or people I work with, to just share that education.
Well, you really have spoke quite wonderfully today, Abi. So thank you so much for sharing your story with us, and thank you, Dr. Currie, for your expertise and guiding us on this discussion that we've had today. I hope everyone has found it as fascinating as I have. And as well as thanking you both for your input, I want to thank you both for your company as well, because it's been absolutely wonderful sharing this conversation with you. My very best wishes to you both for the future. And thank you so much for joining me on the podcast.
Very welcome. Thank you very much for the invitation.